ladies and gentlemen, please welcome to the stage Foreign Policy CEO and Publisher, Andrew Solinger.
Good morning, everyone. Good morning, everyone. There we go. Want to make sure the coffee hit appropriately or ask you to get up and get another cup. Thank you for joining us this morning. And those of you who are still out in the hallway, please do join us and come on in and take a seat. Welcome to all of you. Welcome to our many watchers and listeners online right now streaming. We are here this morning because the future of global health will be built in cities. Urbanization is reshaping the health system faster than most systems can manage. We have growing populations, complex care needs, and deepening inequities, and that expands the role that cities play in who gets access to care, diagnosed time, and who gets left behind. At the same time, urban centers are uniquely positioned to act. They hold the data, the proximity to communities, and increasingly the political will to make change and a difference faster than national systems can. Global health discussions often focus on the higher level organizations, ministries, multilateral organizations, national systems, but increasingly some of the most consequential health discussions and decisions are taking place at the city level. And it's at the scale of neighborhoods, streets, transit systems, and public spaces. This is where also climate change becomes real, when inequality becomes life expectancy and where policy becomes lived experience. What makes healthy cities and the movement behind them in health so compelling is because it's not simply healthcare. It's the interconnected systems that are in cities: transportation, housing, food, open space, urban planning, and social cohesion. So today's program will examine how urban policy and better data can deliver measurable gains. And the goal is not just to identify what's possible, but actually to share what is replicable and what we could take back to our own locales. So I hope you leave the room with some information and learnings that travel with you. Housekeeping notes. There's some stuff in front of you on the table. An excellent foreign policy magazine, if you haven't read. And there's a few QR codes as well. On one side of the QR code, you will find a link to our program and all of the biographies. We won't go into extensive biographical intel when we introduce our speakers, so please do read up on that. And the other side is a link to subscribe to FP, which you all definitely should do. We also have a card on the table with a link to AI for Healthy Cities, an FP Analytics report. FP Analytics is our excellent in-house research division, and they've done a lot of great work on AI for Healthy Cities with Novartis, so please do check that out as well. I'd like to also thank all of our partners on this morning's program: McKinsey Health Institute, MSD, the Novartis Foundation, Novo Nordisk, and the Rockefeller Foundation. We thank them for their critical support. We could not do this without it. So with all that, let's get going.
Please welcome to the stage Denise Cahill, Healthy Cities Coordinator for the City of Cork, Ireland.
Right in the middle. Denise Cahill, welcome.
Thank you.
To our comfy chairs here. We're
Yeah.
sinking in. So importantly, as I was just saying, healthy cities are not just healthier for residents, they're also more economically resilient, and they are more attractive to talent and investment, and ultimately more competitive. So the conversation is really about governance. How can city leaders mobilize networks that already exist to create that kind of environment? So I'd like to kick off, if we would, with just a quick explainer on your role, not your bio as much as what does a Healthy Cities leader do in the Cork example?
Great. So Cork is a WHO designated healthy city from the European Healthy Cities Framework. And we've been designated since 2012. And the best way I have of describing that, and if some of you have a public health background, I'm sure there's plenty of you do, we talk a lot about upstream and dealing with people, I suppose, before they arrive, or dealing with settings before they arrive into health services, which is downstream. So if you can imagine the upstream scenario, and you imagine the scenario of somebody, the analogy of somebody coming down the river drowning and the health services dealing with them. I always tell the story of, if a medical doctor is walking down the street and sees somebody drowning, they're going to intervene. But eventually, if there's more and more bodies coming down the river, there's only so much intervention they can do. So my job is to look upstream and to say what's going on up there, and who can I get together in order to stop this from happening. So my job is to build collaborations and to build partnerships for better health in the city. And that really is about, working not with the health services so much as working with the local authorities in the city. So that's working with maybe the transport division to say, okay, there's a problem with the bridge, people are falling in. Maybe an engineer to fix the bridge, maybe the local police service to close the bridge. This is obviously an analogy. So you're working with very non-traditional partners in the health mindset. And that's my job. So it's basically to provide a platform for people to come together and to look at what's going on in the place that we're living and how can we make it better for everybody.
Excellent explanation. Thank you very much. And the visual of bodies falling off the bridge and floating downriver is one that I think we're working on there. In many cities, a postal code really decides someone's fate inevitably. It's a strong predictor of a healthy versus a non-healthy outcome, rather than genetics, actually. So I was wondering if you could give us an example, a concrete example, if you could, of a street or neighborhood level intervention in Cork that has helped to narrow those disparities.
Yeah, so that's the social determinants of health. So basically your postcode can be an indicator of your health outcomes. So where you live is more important than maybe the decisions you're making, or your genetics, as you mentioned. So in Cork, we have a number of initiatives. There's a number of areas of the city where there's targeted interventions. There is a particular, I suppose I'll give you two very quick scenarios. One is in an area of the city where there's huge investment in early intervention. And that's where from the moment a woman gets a positive pregnancy result, they get a wraparound service. So the services that come in are in terms of supporting the woman and her partner throughout the pregnancy and preparing them for to become parents. Also supporting the child when the child is born up to the age of 5 with a whole range of early intervention services. And that's carried out in areas of the city where I suppose these services are particularly needed, and it's just in those parts of the city. So the reality of that is that other parts of the city would love to have these services and would love to see this taking place. But this is targeted intervention, and that's early intervention, and that's working really well. And I suppose 10 or 15 years down the line, the positive impacts of that are being visible. Children are going into school with good language skills, with the ability to stay in education, with a better chance of coming out of education and getting a good job. And all of these things lead to better health. But the family is supported as a unit. So that's one example, and that's called the ABC program, or the Early Intervention Program in a part of Cork City. Another very quick example is an area of the city that doesn't receive a lot of, we'll say, financing or funding because they're not strictly meeting certain criteria, and there's a lot of work going on there in terms of community food growing. And that has built a whole community around social inclusion, but also an understanding of food and where food is coming from. A fantastic community garden and a whole range of activities coming out of that. And again, that, because it was that intervention took place in a particular area of the city, now other areas of the city are doing the same, and there's 27 community food growing projects have spawned out of that small project. So this is an example of how you target interventions where they're needed, and that proliferates across the city.
That's fantastic. I like the early intervention in particular, which has such a return on investment and a long-term return on investment. So you really need to be patient with that as well. That sounds
100%.
wonderful. Congratulations. Health is often thought of as the purview of the health department, but you've really focused on coordinating activities between officials who really are not focused on health.
Yeah.
Be that in transportation or urban planners or community groups or businesses. How do you get them to think in the healthy city mindset, and how are you working to mobilize those different sectors in the city of Cork?
I think that's the most interesting part of my job, and what I've learned, I've been doing this for 15 years, what I've learned in that process is that all of us in our different professional roles talk a different language. So I've become multilingual in this role, and that's, I only speak English and Irish, by the way. My language is more of the intersectoral nature. So when I started off, I remember trying to convince an engineer that they should do health impact assessments on the projects that they were doing. And health impact assessment isn't mandated in Ireland, it's not a legal requirement, but I was trying to convince him of, how important this was. And I really couldn't understand why he didn't see it from my perspective. 15 years later, that same department, we started talking about play and bringing play to different parts of the city. So we found a different language in which to communicate. And as a result of just doing small interventions around play in a particular area of the city, suddenly pedestrianisation became something that caught on. And the area became pedestrianised, and now it's this really fabulous recreational space called the Marina on the south side of the city. And it's just fabulous. But it was play that brought us together. So what I've learned is there's a different language that you have to learn. You have to, I suppose, open up your mind to what those different sectors are looking for. Listen to what their objectives are. Listen to what they're about. Because placemaking was a factor in his role. Play development and pedestrianisation was something that, as a Healthy Cities coordinator, I was looking for. And by coming together, they worked really well. So the tool we use for that, and a tool that's really useful for bringing organisations or sectors or divisions or disciplines together, is the Place Standard tool, which was developed by Public Health Scotland. And the great joy of that tool is it's all about urban planning, but it's really about health. And the word health does not appear anywhere on that tool. It's freely available to download, it's online. It's a fantastic tool to engage and to talk at a level with communities in terms of the place that they live in. And everybody loves to talk about their community. But also for planners and engineers and health professionals, academics, to come together and to co-design. As such, so it's a fantastic tool for that.
It's actually
purpose.
a tool that you can use to figure out how to navigate in your community.
In your community, and what's good in your community, what could be better, and starting to talk about solutions. So we've used it in Cork in terms of food. We've piloted it to look at the food environment. And it was so powerful, because if you bring a group together and start talking about food, people tend to shut down because they think you're judging them on the decisions they're making about their food choices. But what the Place Standard tool does is it takes you outside of the personal decisions that you're making to what's going on in the environment around you that helps you to make good choices. So you start to think about, how are you moving around to get your food?
Yeah.
Where is your food? What kind of food is available in your local recreational spaces or schools or workplaces, etc. So it's just a great way of, again, I suppose, helping us to look at things in a different way.
Wonderful. And where can we find this tool?
It's online. It's on the Public Health Scotland website.
We'll take a look for that. Thank you. Since we're talking about language and how you can communicate with other fellow leaders, let's talk about the language of finance, which is one of the key languages we need to speak in English and Irish and every language. How do you demonstrate return on investment to city officials who are responsible for those budgets, or business leaders or developers who probably look at these initiatives as a cost rather than as a benefit?
Yeah, that's a difficult one, because that's not obviously an area of my expertise in terms of finance or funding or profit. But of course, a city needs to be economically viable for it to be healthy and for its citizens to thrive. So the language that we speak in this area is livability, and I suppose attracting people to a city because it's a livable city is something that investors, I guess, or institutions or economic development professionals are thinking about. So if a city is livable, it's going to attract people to live in it. It's going to attract talent. It's going to attract investment. And my own city, I suppose there's huge investment in terms of cultural activities, cultural interaction, livability, good air quality, good standard of living, good quality of life, good green spaces. That's the type of language I suppose we'd be talking about in terms of as a healthy city. But of course, a city that's focused on all of these things is a thriving city. And I guess it's to say that that's where people want to live. And if you want to attract people, then that's what you have to provide as a city.
Fantastic. That makes a lot of sense. So moving beyond finance, let's say I'm a city manager, a leader, and I'm getting started down this path of really focusing on health. And I have limited budgets and all sorts of competing pressures. Where do I start? You talked about a couple of examples of early interactions at birth, food, how to work with fellow city officials. So where do you start? Walkability, air quality, green spaces, food access. What, in your experience, creates those ripple effects that you were talking about?
I have worked with the European Healthy Cities network for the last 15 years, and what I've witnessed across all of the various cities across the WHO network is that every city is completely different. And there's no such thing as one size fits all or one approach fits all. So in multiple projects that we've collaborated on, we've never done the exact same intervention. It has to be relevant to the city. So what I would say to a chief executive or somebody starting off in terms of healthy cities is to say, have a look at what's going on. Start by pausing and looking at what's going on already in the city. What are the assets? What are the things that are really, really good here? And if I was to reflect on that, for example, in my own city, it's community engagement and community development. There's a real sense of community in our city in Cork. So you look at that and you harness that and you, I guess, tap into what it is that people want. If I was to have the budget and was given a certain amount to do something in a city, it's early intervention is where I would go and starting there. But you have to look at the life course. I guess you have to look at not just at that end of the spectrum, but investment for all. But the best way to do that is to ask people and to look around and to see what's going on, to harness what's available and to bring it all together into a plan or a coordinated response. So my approach always is pause first, have a look around, see what's going on, and then take action.
I like it. That's excellent advice. Thank you. You mentioned communities and listening to the people. And we talk a lot about at the level of business and city officials and all that sort of thing. Some communities understandably distrust top-down interventions, especially in neighborhoods that feel put upon and overlooked. How do you ensure residents see themselves as co-creators of these types of policies and interventions?
This happens a lot in the research domain, and I guess part of my role sometimes, I've a phrase that I've just developed. It's kind of like putting manners on the experts to a certain extent, who want to come into communities and take what they can get, do some research and leave. That would be a classic example of how that can happen. And that's that top-down approach or that expert-driven approach. I often hear in the area of climate action and health that we need to bring communities, we need to get them on board. Forgetting that we're all community, actually. We all live in communities. The expertise is in communities. So this kind of, I think, expert level or expert top-down approach is very divisive and very hierarchical, and it's not how we live in our day-to-day lives when we go home from our jobs. So the best approach that I've seen is a community development approach where community health workers on the ground are working with the community, know the community, listen to the community, but also don't act as gatekeepers to the community, because that's something that can happen very easily. So the community worker has to be a conduit and a support, obviously there to work in an ethical way with the community, but not to stop things from coming in either. So my advice always is, let's all be equal here. There's no experts around this table. We're all experts in our own right. We're all bringing something, but the community has the solution. And if they're given space to reflect on that and to think about that, it emerges. And the buy-in is there. And what I would say is, if the community are on board and the grassroots are behind it, what happens at a political level doesn't tend to matter to a certain extent. So if you have a new chief executive or a new mayor or a new, president or whatever leading a particular area, if you have a grassroots commitment to something, that'll sustain. So my advice is invest in community workers, because that's an area that is lacking in investment. And I guess they're professionals that don't get the credibility they deserve.
Fantastic. Well, Denise Cahill, I could listen to you talk for hours on this topic. You've clearly got some great experience that you've shared with everyone on listening to the community, as you just discussed, how valuable early interventions are in creating a ripple effect, speaking the language of your peers and meeting them on common ground in order to make them understand the value of what you bring. Thank you for all you do for the city of Cork, and thank you for sharing your insights with us.
Thank you very much.
Everyone,
Thank
please
you.
join me in thanking Denise.
And now, please welcome to the stage Erica Coe, Partner and Global Executive Director of the McKinsey Health Institute, and Joe Jewell, Novo Nordisk's Cities for Better Health Program Director, for a conversation with journalist and moderator Fionnuala Sweeney.
Thanks so much. Hello, everybody. Thank you so much. No, it's not exactly invisible. Oh, I may never get up. Thank you very much for being with us this morning. It's just wonderful to listen to people and their expertise about cities, and we're going to hear a little bit more. And I would like to turn to Joe first. You're known as, your company is a pharmaceutical company, but I'm wondering, while we hear about communities and obviously their incentive for wanting to make their cities better, what was your incentive?
Yeah, so I guess first of all, a little bit of introduction to Novo Nordisk. Many of you may know we're a healthcare company. We've been around for more than 100 years now, and as part of our heritage, even from when we were founded as a company, we had a sort of a mandate introduced into our articles of establishment that said we had to give back to society. We always had to have a societal perspective in whatever we do. And that carries through to today when we have our triple bottom line in mind. We are a company. So, of course, we have to think about being financially successful and be mindful of our shareholders' interest. But we always have to balance that with our social responsibility. So how we give back to society, how we act responsibly in society, and also our environmental responsibility. So that is our triple bottom line, and that is what we are held accountable to. And we also have an enterprise foundation ownership structure. So we are owned by a foundation, which also adds an element of long-term planning to the way in which we look at how we are operating in society.
So when did urban design come in as something where you realize that you can actually improve people's lives, healthier lives in cities?
So I think we take a look at the environment in which we're operating. We're a healthcare company. We need health systems to be sustainable. And that is obviously a shared goal with society, with governments who want health systems to be sustainable. If you look at the burden of disease out there in the world, and also the burden of disease that we're operating in, chronic diseases, noncommunicable diseases, they make up 75% of deaths around the world and lots of premature mortality. And one of the best ways to actually tackle that burden, make health systems sustainable, is to focus on prevention. where do most people live? Where can you meet people where they are? That's in cities. We're about to have 70% of the world living in cities by 2050. And where can you make a change? I think Denise before us was talking really passionately about the possibility to make change happen on the ground at city level because of the ability of cities to convene multiple stakeholders, make the change that happens in people's everyday life, whether that's the food that is available to them, whether that's the opportunity for physical activity and play, whether that is actually making sure that the services that people need meet the communities that are most disadvantaged or underserved. So we opted for a city focus for our social responsibility, for our prevention effort. And we started 10 years ago with our first city, more than 10 years ago now, 11 years ago with our first city. We've now grown to 54 cities in our Cities for Better Health network, which is our social responsibility effort in the prevention space, working locally on the ground in more than 50 cities with government, with civil society organizations, with academia, and of course with the private sector, because we do believe that the private sector can play an important role. And we focus on the daily conditions for health and well-being. So we focus on food, making sure that people can access a healthy diet, and physical activity, making sure that people can be active as part of everyday life. And as to Denise's point, every city is different, every city is unique, but taking that as a starting point, how can we create local solutions that are evidence-based and drive impact?
Thank you. Erica, you're obviously very intimately involved with health and in your role at McKinsey Health. Do you take a wider holistic view of cities' needs? How do you approach the whole question of what a city needs, because as we heard from Denise, not one size fits all. So,
Right.
so where do you come in? What's your trajectory coming in to a city?
We very much think at McKinsey Health Institute that there is opportunity to add years to life and life to years. And we know that health is so much more than what sits within the healthcare system, and that if we're not finding a way to impact all of the modifiable drivers of health that are outside of the hospital or the physician's office, that we won't achieve that goal of advancing health. And so what we tried to do is we have started with picking 3 different cities across 3 continents with a mindset of scaling what works. So often it is not actually a lack of evidence that is the problem, it's a lack of being able to scale. So what is the sustainable financial model that will help us scale interventions that we know work? So when going into a city, figuring out the right mix of cross-sector leaders that are motivated. What is the right, I love Denise's point on being multilingual. What is the right language to speak to be able to identify the incentive for each organization at the table? We know that there is a shared incentive and that health is an investment, not a cost, and it's just a matter of teasing out what is that business model to be able to then show how the investment can pay off.
Okay, so give us an example, if you will, of one of the cities that you may have done some work in
Sure.
recently, and what the challenges were, what the challenge was, and how you went about tackling it.
So one example, and we have some cards in the back, we just produced a video and impact story of this. We did some work down in Santiago, Chile. What was really inspiring, actually, when we started in the community, we did not go in with a here's the problem you're going to fix. And so it was getting 2 mayors at the table from very different ends of the political spectrum, a cross-sector group of leaders that really had a pulse on what the community needed with data. And I know, Joe, you use a variety of tools as well. You need to be evidence-informed. So where are the true health needs in the community? And then aligning around biggest need. And for them, without a doubt, it was mental health. So knowing that we will never achieve any sort of health overall if we are not meeting underlying mental health needs, and how to fix the access gap in the community. Interestingly, both for youth, for all high school students, and then also for elderly, because often this need is universal. And then that led to figuring out where were the underlying costs and who could have a financial incentive to be able to keep a model sustained.
And presumably cultural considerations come into play as well
Yes.
in different cities and how you approach. Can I ask you to speak to that, Joe, in particular? And
Yeah.
I know obesity is one of the challenges that you have been looking at
And
quite seriously.
Maybe also using Erica's examples as a springboard, and 2 ends of our 10-year history. So one of our first cities was our home city of Copenhagen, and a part of the city called Tingbjerg, which is in the north of the city. And when we started working there, they had an incidence rate for new diagnosis of diabetes at twice the national average.
Okay.
And it's a very ethnically diverse part of the city, but economically deprived. And we had to work with the community, with the people living in the community, to work out what are the solutions. And one of the solutions was to take healthcare out of the doctor's office and into the community. Think about the health promotion initiatives that could take place in multiple settings. So whether that is in community gardens, whether that's in the community centers where people go, whether that's in the job center, etc. So use opportunities for health promotion there. And actually, sort of 7 years, 8 years later, we found that the incident rate had equalized with the Danish population average. So it actually works, that type of approach. It takes time. You have to co-create with the community. You have to think about the new settings to reach people. We also, at the other end, childhood obesity, so some of our more recent initiatives where we're working across 6 cities around the world and in an initiative called our Childhood Obesity Prevention Initiative, working in Canada, Brazil, South Africa, Japan, and Spain. And what we're doing there is actually saying we know that childhood obesity prevention in the community can work. There is evidence from a few countries around the world that they can actually sort of bend the curve or flatten the curve. But what hasn't happened is, at scale, replicable. How do we take this to different countries, to different communities, work out what works in different places, and then how to replicate it? So that's what we're trying to do there. And I think the synergies that we also have across our approaches means that there is an opportunity for, whether it's private sectors, municipal governments, or foundations to work together. And I know later in the program you'll hear from Anne with the Novartis Foundation, but we have very similar concerns. We have very similar problems to solve out there in society, and we do aim to come together. So taking inspiration from the Copenhagen example, taking inspiration from the work that they are doing with Cardio for Cities, we're actually trying to come together to meet the needs of the cities, because we go out to the cities and they say, we have a need, we would like to learn from you, we can work together with you, but please don't come with separate
agendas,
parallel programs and agendas. We would like you to come together. So that's what we are also trying to do with our work with Novartis Foundation as well.
And presumably communities are at very different stages of, they'll know what they need, but they may be at very different stages of evolution in terms of how organized they are and the knowledge base that they might have in terms of dealing with it. And that's not to underestimate or take away from communities, because the co-creation is vital. How do you take, if it's not a one-size-fits-all, how do you take the learning from one particular situation, I'm going to put this to Erica, where something might have worked, and try and replicate it in another city with very different, same causes, but very different approaches to dealing with it, very different ingredients in terms of the agenda that the communities might have?
Yeah, it is interesting because the 3 locations where we first started have very different starting points. So one in Philadelphia, much more of a private sector led. So Ken Frazier, the former CEO of Merck, has established a partnership for nutrition and health, and we were able to team up with him and a leading grocery chain, a health system, a health insurer, but very much more coming from the public sector side to get work going, whereas our work in Abu Dhabi, the end of the spectrum, right? So that's very public sector driven of a 3 million population-wide obesity prevention approach. I think that often it comes down to figuring out where is the trust, where are the trust-based relationships, and who are the kind of influential decision makers in a community, getting that buy-in and guidance, and then going from there.
And just a word to you, Joe, about where do you see your work going in the next 4 or 5 years in terms of what you've learned over the last 10 years? Presumably you're adapting and evaluating everything all the time. How do you see it evolving?
Yeah, I mean, I think there's two ways in which it can evolve. One is around the process evaluation style thing. Like, what are we learning from doing, right? So just to extend on from what Erica was saying, like, in our Childhood Obesity Prevention Initiative, we're working simultaneously in 6 cities that have a broadly similar shared framework, but adapted to local context. But it's amazing how much those 6 cities who are working in parallel are learning from each other and exchanging. So we have Mississauga, which is just outside Toronto, and Logan, just outside Brisbane, who are exchanging around how to engage with diverse community groups of different backgrounds. We have Madrid, who is inspiring Chiba City in Japan around how to institutionalize and embed it in, like the city administration for long-term sustainability. We have Campinas in Brazil that is engaging 8 different secretariats across their government, but to reach the different sectors, and it's at the forefront of that. So I think there's so much in the how to do it that is can be learned and shared, and that's one where we're going to go. And then I think, you know, we have not artificially, but, you know, we work on primary prevention in the community. So how to ensure healthy food and physical activity for children so that they stay healthy longer. But there is also something around adult at-risk populations who, you know, could benefit from secondary prevention, and how can we work on both of those in parallel, and maybe something around the family being the unit which brings them all together, right? In the space that we work in, if people who are living with a chronic disease or multiple chronic diseases, living with obesity, typically as a family, maybe the child will be at risk of developing overweight or obesity. So how do we actually use a family as an entry point that has a primary and a secondary prevention element? So I think maybe that's the future direction for where we're going to go.
No shortage of ideas. Thank you both very much indeed, Erica and Joe, for joining us this morning.
Thank you.
Thank you.
Okay.
Thank you. Yeah. Thanks. Thanks. Thank you. You two go ahead.
Next, please welcome to the stage Dr. Patricia Clark, Secretary of the General Health Council for the Mexican Ministry of Health, Dr. Mariana Faria, Director of the Department of External Relations, Partnerships, and Resource Mobilization at the Pan American Health Organization, and Chirfi Guindo, Executive Vice President for Strategic Access, Policy, and Communications at MSD, for a conversation with FP Executive Vice President Allison Carlson.
Good morning, everyone. Thank you for joining us. It's exciting to see a packed room, and thank you to everyone for joining us online as well. Really excited to follow up on the previous conversations and really bring down what we've been talking about yesterday at our Global Health Forum at a little bit higher level to the impact and issues at the local and regional levels, and specifically for this conversation, talking about closing the gap on women's cancers. Cancer, as you all know, and cancer for women affects us at all times of our lives. While we're working, raising families, leading a household, and the impacts extend far beyond the individual, extends to our families, to our communities, and I can bet that every single person in this room and everyone watching online is affected in some way. It affects all of us, and it means that all of us have a role to play in addressing the root causes and preventing cancer and treating cancer as early as possible. And so the reality, however, is that the outcomes really depend on geography and access. Where you live really matters. And as Andrew was saying earlier, the zip code where you live really matters in terms of outcomes and access. In some instances, you can get routine checks, have preventative care and screenings, and in others, diagnosis comes far too late and treatment far too slow. Women's cancers is actually a test on our systems to understand to what degree they're integrated, they're prioritizing prevention and access, or the degree to which they're fragmented. And we have an opportunity here to talk with several experts coming from Latin America, Mexico, and have perspectives from around the world on what's really happening on the ground and what policies need to be prioritized to really, really close that gap and address prevention. So Dr. Clark and Dr. Faria, I'd like to start with you first. You know, we're living in a volatile geopolitical environment, a fragmented environment where there are so many competing priorities. Rising costs of living, security, a number of issues that have the focal points and attention of governments and policymakers. So why should women's cancer remain on the policy agenda, and what policy actions could really make a difference? Dr. Clark, I'd like to turn to you first.
Thank you. Thank you very much, and thank you for the invitation. And well, women cancer in our country is a priority. For example, breast cancer is the first cancer in women, and unfortunately, many of them end up having diagnosis late and unfortunately death. So in our country now, it is very important, and we have really getting into very early diagnosis. For doing that, we implemented a policy in primary care. So what we are doing basically are protocols, and we have, just in March, we started with the protocol on breast cancer, which is a national protocol for primary care and for specialists. What we are doing there is for primary care physicians, a very nice infography and a very nice protocol that is going to be followed by every single public and probably private institutions in Mexico City. Well, no, in all Mexico, not in Mexico City. We're intending to, these protocols has to be mandatory, and it's for population, even rural population, because we have, several problems with the rural population regarding to breast cancer. So the implementation of this tool, which is the program, will be into a broader program in Mexico for 2026-2027, in which we're going to invest more than 800,000 pesos in breast cancer, million pesos in breast cancer, and we're getting one center of women cancer every state in Mexico City. So we're getting imagings, and we're getting specialists for every single place in Mexico City.
How did you make that a priority in this very complex and volatile context?
Because of prevalence, and because, the high cost, the prevalence of cancer, woman cancer in Mexico. We're developing also for cervical cancer the very same thing regarding these pronouns, the protocols. So we will be also working in cervical cancer soon.
Excellent. Thank you. And Dr. Fria, when you hear that about what is being prioritized in Mexico, and you bring that up a bit to the region and the work that you're doing in PAHO, how are you making women's cancer a priority in terms of your programs, your investments, and your actions?
Thank you so much. Good morning, everyone. Buenos dias. So I think when we look at the numbers, it makes an easy case, right? We have 60,000 women that die in Latin America and the Caribbean from breast cancer, and 40,000 women from cervical cancer, which could be completely avoidable. So we're talking about 100,000 women every year in our region dying from breast and cervical cancer. But when we think about that, even this number being a horrible number, it goes much beyond that, because in our region, nearly one in each 5 households has a woman as the sole breadwinner. So when a woman dies from breast cancer or cervical cancer, we're talking about impacts in their children, in their futures, in their household, in the society as a whole. So that makes a very impactful case when we're thinking about 100,000 women dying per year on cancers that could be avoidable. And what we're doing, and it's great, we're very aligned, it is strengthening primary health care so we can give access. Women's cancer show us how inequitable systems can be, right? As you said, it is about the zip code. And so we have some strategies in the Pan American Health Organization that we're working very closely with Mexico and all our other member states. So one of our tools, it's the revolving funds. We have those pool procurement mechanisms, right, where we purchase. We started over 40 years ago procuring vaccines for the region, where we can offer a much more affordable price. And when we think about HPV vaccine now, we're very happy to say that from our 51 countries and territories in the region, 49 of them have already incorporated HPV in their national immunization plans. So we're almost there, very, very close. And 24 of them have already incorporated the one dose, which then gives much more access, right? So that's what we're looking for. And then we have the Alliance for Primary Health Care, where we want this renewed primary health care to really tackle not only what we used to do, which was maternal, child immunization, which is very important, we need to continue doing, but also NCDs, mental health, and cancers go into that. If the solution is not near to where women live, where women work, we will not really guarantee access.
Thank you. I appreciate that focus on primary care and the specific and concrete examples you shared about kind of what supports and what mechanisms are being put in place to provide that support to gain access to primary care. Chirfi, I'd like to turn to you, and from your work and from your perspective with MSD, what are some of the biggest barriers to access that you're seeing in low and middle income countries in particular? And when you think then of the policy setting, what are some policy approaches or policy strategies that you think could have the biggest impact on access?
No, thank you, and good morning, everyone. It's really a pleasure to be here and share this panel with distinguished experts. Maybe a little bit about the good news, because the science is breaking in ways that we have not seen in a very long time. A woman diagnosed with breast cancer early today, you are almost 90% plus chance of survival at 5 years. So I agree with you, Mariana, that these women who are dying in Latin America of breast cancer really should not be dying, because we have the tools to really treat them if you are able to screen them early, right? Diagnose them early and provide them the treatment that we know works really, really well. And cervical cancer, even more so, right? You can actually avoid cervical cancer almost entirely through vaccination. So we have the tools, and we continue to do research. It's really exciting. We haven't talked about ovarian and endometrial cancer. These are also very important areas of high unmet medical need. The good news is we have data now that shows that you can really intervene in those difficult cancers as well, because these are not screened as often as breast cancer, but they're also important to address. Certainly, MSD is investing. We're investing very heavily in research in all of those areas. And gynecological cancers in particular have traditionally been neglected. I think it's fair to say that in terms of research, and that is not the case anymore. We certainly have really good news. Now, in terms of the barriers, I think, women's health in general is an area that requires attention, right? And women's cancers is just one example of the many areas where women's health really needs much greater political attention, much greater advocacy. And this is why I'm really glad that this is now a theme of this panel. Countries are challenged. We all get that, so they prioritize other things. So I think it's really, really important that we address some of the cultural barriers, some of the infrastructure barriers that exist in many of the countries, especially in the LMICs, but not just in LMICs. In high-income countries, you have areas and regions where access is a problem, right? So infrastructure, financing, cultural barriers, and stigma, right? And unfortunately bias as well in the healthcare systems. So those are all areas that need to be addressed, in addition to really making sure that diagnostics are available early and the treatments are available. And those, as I mentioned, those tools exist today. And so we look forward to playing our part.
Yeah, thank you. And on the spirit of playing your part, and in the spirit of this session about partnerships, the list of issues that you just outlined, which are all incredibly important, require collaboration and partnership, no doubt about it. And so I'd like to turn back to the two of you, Dr. Clark and Dr. Faria. When you think about civil society organizations and the role of the private sector, from your perspectives and in your work very concretely, what kinds of partnerships are really having an impact on outcomes as they relate to women's cancer and cancer care?
Well, okay. Patients are very important, and patient society is very important in this case, because they help us to disseminate our protocols and the things that we are doing. So we're very close to them. We are very close also, not only to the public system, also to the private system in my country, because I mean, health is for everyone, so we have to have everyone who is, doing something in health, in women's health. The other thing that I consider very important, and we use it always as a tool, is the gender perspective. Many of the barriers that you were talking about has to be with, or are very related to health determinants. And those health determinants in my country are so important because there are important barriers regarding cultures, regarding what women do in my country, which is the place why they don't have access. So we are also working in these type of things, and we are doing a real effort to get to everyone in the country, not only in the big cities, also in the small cities, and that's why this infrastructure that we are building over these 2 years are going to be everywhere. And we hope that having this very early diagnosis in primary care, we can close, the timing, and we can get women early in regarding the treatment and hopefully the survival.
Great. And Dr. Faria, for you?
So I'm going to take the opportunity to say that PAHO is very committed with our member states to make the Americas the first region in the world to eliminate cervical cancer. So we have elimination initiative, and for that we invite others to join us in this because it is feasible, it is possible. We can do it. We can do it for all the women in this room. We can do it for all the women in the region and in the world. We can show that it's possible in our region, and then other regions will do it as well. We have a wonderful partnership with MSD for women's health, and we want to expand those partnerships. So we see the value of the private sector, as you mentioned, in research, in bringing all the products. We have another revolving fund, which is a strategic fund where we procure diagnostics and treatment, because that's the other side, right? We need to diagnose early, and for that we need to overcome barriers. So we need self-diagnostics. It's very helpful for some of the regions that we have, rural, but also some religion barriers that we face in the region. And then working with the private sector also to guarantee access through prices and through products that can really find solutions for the barriers that we face. It's very important, but we need to go beyond that. So we have a very big scope of partners going from Spain to Unitaid, MSD. We have civil society, ProMujer. I don't want to forget anyone that is supporting us in this walk, but we want to invite others as well to join us. We know this is feasible. We know this is possible. And as we did with polio, with measles, we can also be the first region to eliminate cervical cancer and show that this is possible for every woman everywhere.
I love that ambition. And also the invitation to everyone in this room who is part of this journey, as you said very well at the outset. And that ambition for elimination is incredible and inspiring, and also takes resources, right? And so, Trivia, I'd like to come back to you on that note. All under fiscal pressure and recognizing budget constraints, but where can the funding that is being mobilized and does exist, where can that be targeted for outsized impact?
Yeah. No, thank you. So I really love the ambition, Mariana. Congratulations. And so if you allow me to also talk about our ambition as a company, as MSD, we talk about this a lot internally because we want to be the company that helps, along with all of the partners, to prevent cancer, to treat cancer, and hopefully to cure cancer. That is really our ambition as a company. So we're investing every day, right? So the 76,000 people who work for our company are motivated by this ambition. So really, we are in it with you. So we really applaud your ambition, and we're here to also work with you and with everyone, really, in the public health arena to move towards that ambition, right? So back to your question about funding. I think there's a mindset that really needs to be talked about, at a high level. Intervening in women's cancers should not be seen as a burden. It should be seen as an investment, right? So there's a really, nice study. Multiple studies have been done, particularly in breast cancer, showing that if you invest $1, right, in diagnosing early and treating a woman, right, with breast cancer, you're going to get $6 to $8 at the back end, So the ROI is extremely high for the case of breast cancer treatment, diagnosis and treatment. So I think we need to just make sure that the policymakers really take that into consideration when they do their resource allocation. And it is a fact that money is tight. Defense budgets are having to be increased in a number of markets, a number of countries. So governments are constrained. But this is one area where the ROI is very, very clear. So our case, our collective case, is to really make sure that the politicians who make those decisions understand that, and they understand that putting resources behind this is going to pay back. And as an industry, we're going to do our part, right? You talked about pricing. We are going to do our part to make sure that pricing is not a barrier, right? So infrastructure is the most important barrier. Cultural issues that we talked about, very, very important barriers. Religious issues in some cases. And so certainly pricing should never be, a barrier. We think about innovative financing schemes. In India, for example, we have a very successful model where we have a means-tested approach to accessing our cancer drugs, right? So this is something we're doing in partnership with local players, local insurance companies. And so those are some of the models that are being tested that we need to scale. But for that, we need partnership.
Okay, well, we're out of time, so I'm going to ask a quick speed round to close us out here. And in that spirit of ambition and the call to action, which you have clearly made, when we come back here next year, and hopefully we'll be sitting on the stage again together, what will need to have happened in the intervening 12 months for each one of you to say real progress has been made? We're further along than we are now. If you could really crystallize that concisely, I would appreciate it. And then a year from now, we can see what progress has been made. Dr. Clark.
Well, I could say that at least we're going to have half of the things that we are talking right now regarding the infrastructure, the dissemination of those pronouns, cervical cancer and breast cancer will be also a priority. And just talking about cervical cancer, also we have a big problem regarding vaccination. So we have follow-up 2 years of vaccination to every single boy and girl, the fifth graders. So we hope to keep doing that. The other thing that we have, because always a year is just small in health. Health takes time to do things. To avoid cervical cancer, you at least have to have this vaccination in children at least 10 to 12 years to see in 20 years a real, descent on cervical cancer. So we have to see it also not only in the short time. We have to see this in the long time.
Great.
I would say we want political commitment, but financing. We want access. We want to make sure that we have more girls vaccinated, more women screened, more women treated early, right? And for that, we need a strong primary health care that can respond, that is close to people, and that really can give access to women everywhere.
Excellent. And Sherfi?
Two things. Number one, major breakthrough in endometrial cancer research and ovarian cancer research. That's number one. Number two, greater access to breast cancer and cervical cancer. The tools are there, right?
Yes.
For those two, we just need to execute.
Excellent. Thank you all for being with us and for your work on this very, very important issue. Thank you. Excellent. That was wonderful. Thank you.
And now, please welcome to the stage City Cancer Challenge's CEO, Isabel Mestres, and MSD's Vice President and Head of Social Impact and Sustainability, Dr. Kaylon Taylor Clark, for a conversation with foreign policy publisher and CEO, Andrew Solinger.
Are we well seated?
Sorry?
Are we well seated?
You're well seated. I think it works. Where as long as you're seated, you're well seated. Hello, everyone. And as we move forward with the program, talking about partnerships, we want to really explore exactly how some of these partnerships work, specifically on women's cancer. That was a very enlightening conversation. We'd like to deep dive on that. And I think we're actually going to have discussion of some new partnerships that are just being announced. So stay tuned for that for a moment. But I wanted to kick off, Isabel, with you to talk a little bit about the City Cancer Challenge, a little bit about the work that you do at CCAN, and what the value of partnerships are, why they're so critically important, and why they make a big difference in these in combating cancer in cities. Maybe you could just kick us off with that.
Thank you. Thank you so much for inviting us. Thank you.
Of course.
Well, hello, everybody. I am the CEO of City Cancer Challenge Foundations. For those of you who don't know us, we work with countries in low and middle-income countries to improve access to cancer care, but we do it from the ground up. We do it at the city level. And I'm not going to explain the whole model, but just tell you that the city is a perfect ecosystem to actually drive national policy and change to improve people's life. Because in a city, you can see the whole ecosystem in a smaller scale. We are able to move from traditional vertical interventions we've seen in the past, disease-specific, single interventions, to horizontal interventions. Patients don't go one time in the system. What we're seeing in low-resource settings is actually patients getting lost in the system because of the lack of connection between primary all the way to supportive care. So to that, why partnership? I'll go directly to partnerships, because what we've seen over the last year is massive innovation in oncology. Actually, we're in Geneva. We've seen normative work done in oncology. But what happened? That when we go to the ground, low-resource settings are not prepared for this innovation. Patients get lost. Patient doesn't arrive on time for the diagnostic. Patients abandon treatment because simple things like choosing between transportation to the hospital or putting a plate to their children. So we need to work with partnership with organizations, companies like MSD and others, where actually they understand innovation. And then it's how do we work together to make sure that the system is ready. And that's where we are we've been working with MSD and others for many years, trying to combine these. How do we bring these normative evidence, innovation into the ground? And what we are good at is implementation. So we are actually reaching the gap of implementation. That is what we're actually seeing in low-resource settings.
Wonderful. And just to follow on that for a moment, why cities? Why is it important to do this in cities in particular?
Cities is specifically because we can move to horizontal interventions. We can tackle the whole system. Just a few examples.
Sure.
We can tackle the whole, for example, in Georgia, we've been working with across all the institutions, hospitals, government, reimbursement systems, like at the meso level, connecting the system, bringing evidence in the ground on what are the gaps of the patient journey with data has allowed the local stakeholders to come up with solutions that are contextualized. Because what happened is that all these guidance are based on evidence from high-income countries that are not translatable. So by working at the city, in addition to set up the quality, connecting the system, improving the workforce, we've been able to change policy. So we've been able to increase, by just working all of us together, the system, the limit of medicine coverage from 2,800 to no limit. Diagnostic was not under universal health coverage. Bringing protocols on diagnostic, costing the diagnostic, we've been able to include diagnostic under universal health coverage. We expand the medicine list, the essential medicine list. And one interesting thing, we were able to put across the whole country, and this was evidence from the city, pharmacists in the hospital. Because imagine, like, people were going to the pharmacy and with these expensive medicines without quality control across their house, their friends, and now all the hospitals. So Georgia has embedded our city model, bringing stakeholders together. They elevate it nationally, and it's just fascinating. We're working a lot with the WHO and other agencies in that country.
And I would imagine in a country like Georgia in particular, where so much of the population and society is based in that city, there's immediate impact on the entire country as well.
Exactly.
That's fantastic.
And
Please, Kayla.
Just as a point, and I'm going to reinforce what Isabella is saying. In many of the cities where CCAN has been, we've seen, what I love about locally led solutions is that we can actually see the outcomes, right? So another specific example of that is in Kigali, in Rwanda, where we worked along with other partners to look at the time from diagnosis to treatment for breast cancer. And what we were able to do with what CCAN was able to do with a patient navigation program was to reduce the time from diagnosis to treatment for breast cancer by 65%, from 82 to 28 days. These are the kinds of outcomes that a company like mine loves to see, because we know that we're actually putting our resources in places that matter and places that are going to have impact. Another example was through GBCI as in CCAN, the work that we did in Cali, Colombia. One of the issues that happened there was thinking about breast cancer and the fact that women were being lost to follow-up. A lot of women were being lost to follow-up, and so therefore the outcomes were terrible. What we were able to do, or what CCAN was able to do through their patient navigation and diagnostic coordination and patient supports, was to reduce that time of loss to follow-up from 44 to 21%. These are the kinds of outcomes, again, that when you're thinking about investing in real solutions, the city level is a wonderful place to be because we can see those outcomes more quickly, but it's also a place that then we can say, what did we do here that we can scale? And I'm all about doubling down on scaling.
Also bringing up those metrics and measurements where you can prove the value of what you're doing. It builds support for you as well, I'm sure, internally for the great work that you're doing. That's 100%. Fantastic.
A lot of times we just say, oh, we're investing in social programs, but what does it mean to actually do such?
Of course. So, Kaylan, the suspense is killing us.
Yes.
I know you have an announcement that you want to make here at WHA. Tell us a little bit about what you've got.
This is hot off the presses, everyone. We have an announcement to make with City Cancer Challenge that we are going to be investing in a 5-year, $10 million investment to improve cancer care for women. This is going to be called Thriving Cities and Healthy Women Initiative. We're very thrilled to be able to be partnering yet again with City Cancer Challenge. I don't know if all people know, and I think my boss here, by the way, is Shurfi, so we have to be on our toes.
But she's doing great, Shurfi.
We're trying here. But it's important to understand that breast cancer, cervical, ovarian cancer, uterine cancer represent a growing challenge, not just nationwide in the United States, but worldwide. Every year, more than almost 2.5 million women die prematurely from cancer. And we're thinking, and if you look at the research, it shows that as many as 800,000 deaths can be averted in women's cancer. They could be avoided annually through a combination, of course, of effective public health practices, earlier detection, which is something that we've been thinking about a lot, and of course, timely access to medical care. So this 5-year commitment is really going to be catalyzing, and that's how we see ourselves, as catalyzing commitment. So we don't need to be the only ones here. I think there's some people in the room that I hope will join us. And the idea here is that we would get to 300,000 women living with cancer across 15 cities by 2030. So we're thrilled about that.
That's fantastic. Do you have specific cities in mind that you're targeting? Maybe, Isabel, you could share?
I can, but it's mostly our network of cities. So we're going to be targeting Philippines, Cambodia, new city. We've just announced a new city, Kochi in India, which is a fascinating place. We're going to be testing a lot of innovation there.
Have you been in India already, or is this?
So we've been as due diligence.
Yeah.
But now it's officially they're joining our network of cities. And it took me a while because I was a bit like, India is, it's not easy, but we cannot miss the opportunity of learning with them.
Yeah.
So we're going to go also in cities across Africa, so in Kenya, Nigeria, Cote d'Ivoire, and Latin America, Mexico, Chile, Argentina. It's going to be a spread around and a lot of different systems, a lot of learnings. And I would like to say a few words. First of all, I'm really grateful, of course, to MSD. It's not new for us. We've been working with MSD, has been one of our first partners when CCAN was a white page. So it's been a journey. And that explains what it means working in partnership. It's building trust, because at the beginning, there was no numbers. No numbers. It was an idea. But building trust, learning together, accepting failures as learnings, being open and transparent. I'm seeing now Alexander, whom we've been discussing a lot over the years on the learnings. And then by seeing together and learning together, we are at this point that we know we have something very good. Together we've built something that has impact. We have a no-brainer, as MSD says, on our model. It's the best, like cities are the best mechanism to actually generate system data, bring interventions, because a patient doesn't navigate in a country. And the policy people need evidence from their own context. So it's the perfect time in the evolution of our partnership now to take it to scale and continue learning and actually doing some innovation in cities. And we're very grateful. And also with MSD, we're working, you want to talk about WHO?
Yeah, we could do that.
Yeah.
So,
Keep going.
Yeah, we're just going to
We're on fire.
Here, no.
Let me know if I get in the way.
We love each other. So this is another partnership that we announced this week in support of CCAN and with the WHO, the Global Breast Cancer Initiative. For those of you who don't know, actually started in 2023 with several different partners, other pharma companies, and now we're re-upping, if you will, we're reaffirming our commitment for 2026 to 2028. And that's really, the goal of which is to really translate the global breast cancer action plans into action, right? So it's lovely to have the frameworks, it's lovely to have the directives, but it's incredibly important that we then can implement those directives. And of course, City Cancer Challenge is a perfect space for that. Again, if we think of cities as the place to actually implement these plans, then we can figure out where do we need to then pull into scale, where can we pull back, and the like. So I think part of that strategy, and there's 3 key strategies and objectives that GBCI is pulling through. The first is, of course, health promotion and early detection, with the goal of getting over 60% of invasive cancers diagnosed. Of 60% of invasive cancers diagnosed at stage 1 or 2. We also hope to have timely diagnosis, again, with very specific and clear goals of diagnostic evaluation, imaging, using multimodal pathologies and treatments without abandonment. And this is a big one. And then, of course, comprehensive breast cancer management, getting to a goal of greater than 80% of people actually undergoing multimodality treatment without abandonment. That was the number. And so this is the kind of partnerships. Again, not just with our own company, but with City Cancer Challenge and other companies coming to the table to really start addressing these issues.
So I want to dig into that. This is fantastic work that you're doing. Congratulations to both of you, and I feel the love and the great partnership here, which is great. What other types of partners are required to scale this? Clearly you have to work with national governments and city authorities and NGOs. What kind of role can they each play in this type of project and effort?
And I will speak for the private sector, and for those of you who are here in the private sector, being able to catalyze these opportunities is incredibly important for us. We don't have all of the financial resources in the world to solve everything, but together we're able to really accumulate resources that would then allow folks to do scaling. Of course, you need the non-governmental organizations as well as governments, and I'm sure Isabel can speak more to that.
Yeah, I mean, the amount of partnerships that City Cancer Challenge moves in a daily life is massive. Yeah. Like, think about, in every city we engage 300 stakeholders. So we're working in partnership with the national government, our main counterpart, but then we also work with the regional government and the local government, different parties, and we make them to work together. In these systems, the fragmentation is massive, so we have to make the systems work together, even if they're parallel, not talking to each other, so we bring them together to start channeling. We're working very closely also with the African Development Bank, the World Bank, to start building those PPPs. PPPs meaning how the public system can leverage better the private system. And this is something we cannot ignore. It's there and we have to tackle it. So another partnership is we're actually setting up the tone on how to bring those collaborations, guidance, and we're going to soon release this document on guidance on how to set up these PPPs. And it's about, sometimes I just think it's about human behavior and willingness. Yes. Other partnerships, of course, we have is the massive is the international hospitals, meaning we have to build capacity local. So we set up a partnership with the Tata Memorial Hospital in Barcelona, in the US, in France, in Switzerland, so that there is these twinning programs and they can learn. And partnership between cities, that's so valuable. For example, WHO made a call for us to support in, I think it's the Kazakhstan or Uzbekistan, one of those two countries.
One of the stands.
One of the stands, apologize. And then it was so easy because we've just gone through the same challenge in Georgia. So we were able to bring the institutions in Georgia to support Uzbekistan.
Yeah.
And it was just magic. And it's just, this is about, we're building partnerships every day. I think I always invite the other communities, because cancer, I mean, with the global health architecture, cancer is not really affected, because we were never anything. We've never been protagonists of anything. We never get funding from any development agency. So we had to find our way on partnerships. That was the only way we could find solutions for oncology. So I really welcome everybody to connect with the cancer community, because we're really good at building partnerships.
I would just note on top of that is one of the things that I've been noticing as I've been going around the world and visiting some of these communities, which I had the opportunity to visit both in Peru as well as León, in Mexico, it was to think about also local governments, right? So there are many different cultures, many different languages in many of these countries. And in order to actually connect people to the right care at the right time, we have to incorporate those people, right? So oftentimes we think of national governments as being the ones that we want to go to without thinking about the people well into the Amazon in Peru or well into the bush in Africa. So these are the places that we're really trying to get to connect people to that care as well. And we can't, I would be remiss if not to say that.
Certainly at the city level. We only have a minute left. I just wanted to ask each of you, and maybe starting with you, Kaylin, actually, because you talked about the metrics and the reduction in diagnosis and treatment times. What in 5 years' time is a goal that you've set for this project? I mean, you are moving so quickly and with so much energy. It's fantastic. What's the brass ring?
So, you know, I always talk about, and my team, I drive them crazy on KPIs. They're sitting over there rolling their eyes. But honestly, one of the major outcomes that we always think about is, of course, people reached, right? So with Thriving Cities, Healthy Women, the challenge will be to reach 300,000 women in 15 plus cities. But it's not enough to just reach them. You know, our ethos is always, what are we reaching them with? And again, this is going to be better patient navigation, better diagnostics, better coordination within the system. And those are the things that we're hoping to be able to also have KPIs around, so that it's not just we're reaching them with something, we're reaching them with something that will help.
That's great to bring some metrics to that. Thank you for explaining. How about for you, Isabel?
Yeah, so maybe you know, but there is 2.3 million women dying every year of cancer. You know we can save all those lives. We know it. They're preventable, and 800,000 could be addressed through treatment and care. Right. We know it. So these people are not dying for lack of knowledge. They're dying because the systems are failing. Mm-hmm. So in 5 years' time, with the partnership with MSD, of course, those are the numbers. But the SICAN is not about 100 cities, 50 cities. We're actually we have a max of 20 quality cities. This is about deep. This is about seeing what it takes to transform a system and bring implementation research, which is the biggest gap we're having today, whatever it takes. So we have 5 years, but we've been also working already in those cities. So our ambition is that in 5 years, we can publish evidence on how to transform a system to avoid that these people die of cancer. And I want to finally thank MSD, because it's not sexy. Let's put it this way. Like this is about 5 years. And it's not going to be quick wins. We're going to have metrics. But this is about the long game. This is not about this shiny new building, this shiny new technology. This is actually investment on a system that is going to take time, and it's not going to be shiny from day one. So I think if there is donors in the room, think about the long game. We've been spending so many money over the last years on silo intervention, silo disease, and those systems are broken. So give the government, give civil society, give the time to think and transform the system in a horizontal way, and let's move from vertical approaches.
Excellent. And I think a takeaway for me in this discussion is that it's not about, as you just said, shiny technologies or new medicines. It's about building systems capable of delivering them. So I want to thank you both for your energy and for the great work that you're doing. And by the way, with that energy, I think in 5 years' time, I hope and pray that your wishes and goals come true.
We appreciate that.
Please join me in thanking Kaylin and Isabel. Please.
Please welcome to the stage Dr. Ann Artz, head of the Novartis Foundation, and Dr. Michelle Williams, professor of epidemiology and population health at Stanford University, for a conversation with Fionnuala Sweeney.
I finally got it.
Yes.
Thank you. Thanks. In this panel, we're going to talk about AI, and that's exploded in our lives over the last year or 18 months. But what we really want to find out today is, what does AI for healthy cities mean? So I have Dr. Michelle Williams, and I have Dr. Anne Arts of Novartis Foundation. So let me begin with you, Anne. What does AI for healthy cities mean in practical terms? If you can give us an example, would be great.
Yeah, thanks. Well, we set out to do a very ambitious initiative, which is AI for healthy cities, for the simple reason that cardiovascular disease, after all the medical progress that has been made over the past decennia, the scientific innovations to address it are there. The technology innovations to reimagine how we address it and bring the care to where people need it, when they need it, even in their living room, we all have it. And still it's the #1 cause of death. The 21 million people per year are still dying of cardiovascular disease. So we seem to miss a piece of the puzzle here. We don't understand what truly drives cardiovascular health, and that's what AI for Healthy Cities brings as an answer. We brought together the data from the health sector with data from the health influencing sectors, such as housing, transportation, food access, security, education, income, you name it, all of the underlying social, environmental, economical determinants, to understand what are the best or the worst combinations of these determinants for your cardiovascular health. And the results of this are quite amazing. You will hear about it today, but for example, one thing we did was taking all of the US data, millions of data. Our partners was Microsoft AI for Good. And with those, we can perfectly predict per census tract in New York, that's a community of 2,000 people, much smaller than a zip code, the neighborhoods. We can perfectly predict what is the lead driver for cardiovascular outcome. For diabetes, for example, 70% of diabetes is predicted by 4 things: low education, needing SNAPs or food assistance, having no access to internet, and living alone, specifically if you're over 65. These 4 determinants drive 70% of diabetes in New York. For hypertension, we know that a long commute time, over 1 hour commute to work, is the #1 driver for hypertension in New York. So these insights help us to stop the blanket approaches in cities and we'll start working on place-based, population-based action. That's what AI for Healthy Cities brings to this conversation today.
So in a sense, it gives you a sense not only of what needs to be done, but the drivers, what's causing it.
Absolutely. If I can just add, you know, we are at a moment in time where we can actually use the analytic tools of AI to really precisely pinpoint where in a city the specific investments in specific interventions can impact drivers. For example, in New York City, we know within that city there's a 20-fold difference in the prevalence of diabetes, type 2 diabetes. 20-fold difference. In some communities, 2% prevalence. In others, almost 40% prevalence. And so with the precision that AI can allow us to see what the drivers are, we can be more precise in how and where we invest in specific interventions. For me, it's one of the most exciting things about public health, because it takes us to a place where we can use our resources effectively, efficiently, in the places within communities that need the intervention the most. And we can evaluate the impact.
I know, briefly, what is the evaluation length of time for you to be able to act on specifics, like to go back to the cities and say, we can do more and sell it to them, for want of a better phrase?
Yeah, it was quite different across the cities. In fact, and Michelle, if you remember, we started in New York with a lot of partners. It took us about 3 years to get the answers. We then went at the same time, a little later, to Singapore, was much faster as the data system is more coherent, already organized in one place. Finland did the same exercise in 3 months because their data system is totally ready to do this kind of analytics. So it depends on how well the data is organized and how the willingness is of the local decision makers to get these answers as well.
And what is their response when they see the specifics in such detail? It must be sort of an unveiling and a view of their city in a way that they would never have seen it before, to have such data.
Totally, this 20-80%, so that 80% of your health is driven by these determinants and only 20% is driven by the health care you access. That reframes your whole conversation. So it brings the health in all policies in reality. In fact, they understand in a city, cities are very agile. The mayors already work with different sectors together by definition. So bringing these sectors around the table together and saying, okay, here it's the security of the neighborhood is the #1 driver. What can we do about it? There it's the housing precariousness, or here it's the long commute time, the time stress. What are the best interventions we can bring to these different neighborhoods? Instead of doing food assistance throughout all of the underserved neighborhoods in the city, we now can pinpoint this neighborhood. You don't need to continue food assistance. You need to find solutions for the elderly who are living alone, and the social isolation is the first driver. So this is the kind of information that opens the eyes and the minds of decision makers in the city to do things very differently.
I'll give you an example. The head of Parks and Recreation might not see themselves as playing a role in diabetes prevention. Transportation, metropolitan transportation authorities might not see themselves in playing a role in chronic disease prevention. Housing, food administrations. When you show these data and you show that the social, environmental, policy, economic status of a community are the drivers, literally driving 80% of the health outcomes in cities, then everyone begins to see that they have a role to play in health. And it gives city authorities a more holistic approach rather than the current siloed way that people dispense with city resources to manage the needs of their citizens.
And are cities embracing that holistic approach? Because one would think that they've been set up for years to be quite siloed, and health is a health department, and parks. Oh yeah, you're looking knowingly at each other.
Well, I sit around the table as we look at these data across cities as diverse as Helsinki, New York, Singapore. And it's fascinating to see the eyes light up of municipal leaders as they begin to see evidence that drives the decisions that they have made or will make in the future.
So their eyes open wide. Then how do they go about the process of turning those insights that they've been provided with into concrete action?
Well, we sit down together with all of the sectors that should be around the table, including the communities. And if I give one example from New York, for example, we saw in Coney Island that there was a blanket approach to roll out telemonitoring for remote monitoring for heart disease. And then we realized with the communities that it was mainly the elderly living alone that were struggling with this remote monitoring. In fact, the digital savviness of certain age groups or certain population groups is not the same everywhere in the city. So what we then did is bring together the community health workers from another area in the city where the problem was not necessarily loneliness, but was rather the time pressure, the long commute time. There we deployed these remote telemonitoring instead in that region, and we brought the community health workers to the region where there were more elderly living alone who prefer a human contact. So this is a beautiful example of how you reallocate resources you already have to where they are needed most and where they can have the greatest impact on the largest number of people. I was in Helsinki last week, Monday, and Helsinki is already a gold standard example of how you work cross-sectoral in a city. The mayor is totally convinced of the importance of the determinants of health and has brought all of these different players you mentioned, Michelle, into his health policies. However, the leader of the health and social services in Helsinki still wants to improve. There's always room for improvement, obviously. And with AI for Healthy Cities, we discovered certain population groups they hadn't been thinking about. And this was, for example, the single parents was a main risk factor for cardiovascular disease. Or middle-aged men living alone in Helsinki with unstable income or not so high income, stable but not very high, single men, they are never in touch with the healthcare system. So these were the groups they are now going to target with the evidence-based interventions they already do, earlier detection and prompt adequate management of cardiovascular risk and prevention, but that's now targeted to very special groups in the city instead of doing it again for the entire population. So you create precision population health approaches together.
So you're talking about a city like Helsinki, and you describe it as the gold standard. What about a city that maybe is experiencing its first AI-driven insights into how it's operating across the board for its populations and different communities? And does AI always prioritize automatically what's the most important challenge?
Well, I want to start by saying AI for Healthy Cities involves not only quantitative data analysis, but also qualitative data analysis. And one of the really important findings that surfaced across all of our cities was the importance of appreciating that individuals and communities need time to invest in their own health and the promotion of the health of their families. So in the qualitative studies that AI for Healthy Cities is also engaging in doing, we learn that time poverty looks different depending on which city you're in.
Okay.
It might be the male, upward socially mobile professional not having time to eat healthy and to engage in physical activity to reduce their stroke risk. And we actually saw that in the data. And it was reinforced by the qualitative data that we have. So it's not always just quantitative analysis. It's also speaking to the population and understanding the lived experiences that they have. Time poverty in New York City looks very different. It could be the single mother working 3 jobs and commuting 2 hours each way to work. And so it really is important to contextualize the lived experience in addition with the data that we have.
And forgive me, is this before you start to implement a pilot, or as you're implementing a pilot, that you're trying to get the community on board? I mean, the city may be on board, but if you're trying to bring the individuals in who you want to help on board.
We did that qualitative analysis within the AI for Healthy Cities work. So it was before we started the translation into action, in fact. So AI for Healthy Cities, we see it as our R&D motor, our engine for innovation. Now we translate that into action by working with the cities. And with different cities, we also integrate these insights that are consistent across the different sites we did the analytics. We integrated in our flagship Cardio for Cities program for translation into action. So that program can become much more targeted and tailored to the needs of the people who live in those cities.
And the communities at the table. Community engagement is a central pillar to the work.
It can't happen without
So it's not top-down. We heard in the first session this morning how important it is to engage the community from the beginning, because they're the ones that we are working to serve, and they are really the owners of the priority-setting agenda.
A wider question. You've got the community on board. What determines whether something moves from the pilot to having more of a regional or perhaps even global impact?
Well, you know, what I hope is that people will take the lessons learned from the 5 cities that we're involved with in the AI for Healthy Cities and learn that there are 3 things that's very important. One is the consistency of the drivers of health across these very diverse cities. Geopolitically, their health systems are diverse, their populations are diverse. Second, that there is the realization that decisions can be made that are driven by evidence, that every city can use their available data to identify where the risks are concentrated and identify what are the factors that drive these risks and impact those factors, as opposed to taking a one-size-fits-all approach. And then third, that what's needed to scale what we know now is the social and political will to get all stakeholders around the table and to commit to addressing these social, environmental, economic drivers of health, and recognize that the real determinants of health really exist upstream, not in the healthcare delivery system itself, but out in the places where people are living, where they are working. If we can address food insecurity, housing insecurity, safe workplaces, education, and address poverty in ways that we all know that we can do, we are impacting 80% of the health characteristics of a population.
And when you say if, what does that take for it to be real as opposed to if?
One word. What it takes is coalitions, partnerships, collaboration. You cannot do this alone. Any kind of player you are in that whole ecosystem, you have to work together with all the others. And a successful coalition can get things to scale. We are proving it with Cardio for Cities, where, as you heard from our friend Joe from Novo Nordisk this morning, we work together with several different private sector players and have the local authorities always in the driver's seat. So the local authorities, the local communities decide on how we prioritize, how we tailor the standard framework of population health to their local needs, and how we get that done together. So the private sector players bring different types of expertise together. The public sector brings that population health approach, which is their mandate, and then the communities brings the legitimacy. It has to work for them. It has to be their program. So this is the combination of a coalition that can work for scale.
A final quick question to you, Michelle. AI is changing how you work compared to 10 years ago. How exciting is it for you?
It's really exciting because public health is a very complex web of drivers. And never before have we had the tools that we have available now to really bring to bear the many different factors, the many different sources of data. We're not looking at a single point intervention. We're thinking about a web of how society drives health. And I think that AI helps us do this, but it's not the only thing. It is the recognition that it's the environment, the social environment, the policy environment, the food environment that impacts health. And if we can think about it more holistically with the aid of the computational capacities we have, that's wonderful. But it takes leadership. AI is not going to be the solution by itself. It really takes that social and political will to drive change at a level that drives equity for access, for quality health care, housing, food, and a workplace environment that allows people to thrive.
It's another tool, in other words.
It's a tool. It's a tool that helps us understand more holistically what drives health.
Michelle Williams, Anne Arts, thank you both very much indeed for this panel. It's great. Thank you.
Oh, thanks.
Excellent.
I stay with you.
Excellent. Stay with us.
I don't know where you want me, the last one?
You're going to be going on first. And then first. Yeah, first. And then Daniela. So then Amy's going to announce at the very end.
Okay. Next, please welcome Dr. Anne Arts, head of the Novartis Foundation. Daniela Foster, Senior Vice President and Global Head of Market Access, Sustainability, and Public Affairs at Bayer Consumer Health. Dr. Lo Lian Lang, Director of the Center for Population Health Research and Implementation in Sing Health, and Dr. Adine Sarouk, Director of the Philips Foundation, for conversation with FP's Allison Carlson.
I'm delighted to be able to build on the last conversation and round out this morning with all of you. We're obviously addressing very serious and complex challenges, but I have to say the energy in this room today has been incredible. And the expertise, the ambition, and the calls to action are really inspiring. And so I'd like to keep up that momentum as part of this conversation. And building on the last, really we're going to dive into cross-sectoral partnerships and what is absolutely needed to build coalitions that are capable of leveraging these data-driven insights and driving social impact at scale. So Anne, I'd like to turn to you first. Often there are references to public-private partnerships, and last year there was a lot of talk of public-private philanthropic partnerships. Very important indeed. But what we're talking about here is a little bit different, and there's an essence to a coalition. And so building on your last conversation, when you're thinking about coalition building, how do you think about that? And why is that important and that kind of change of mindset different in order to drive this impact at scale?
Yes, it is different than a simple public-private partnership. It is bringing together a diverse set of experts, of players, with diverse roles and responsibilities in society. So that is what makes a coalition successful, that each partner brings its specific expertise to the table and is very complementary with each other. So we need to start with, of course, a shared agenda, the shared goal. We have to agree on that. And the goal is to improve heart health in 30 megacities by 2030 for about 150 million people. Let's say that's our goal. Then you need a shared measurement system because the whole approach has to be data-driven. If you want to make sure you get to the results and the impact you are saying you want to deliver, you have to measure that. And the measurement system has to be agreed upon from the beginning. What are the minimum set of data we are going to track as progress and for our impact measurement? That means that when you get to impact, you also have to create shared glory, obviously, as it's a partnership. And lastly, I believe this combination of expertise where the government brings its role of serving the populations they are targeting. We bring, as a private sector, the innovation, the philanthropic capital can do the risky stuff where governments don't have money for trying out innovations. We can seed fund that, and when it works, then it gets scaled. We bring the private sector players like Daniela from Bayer with the consumer health expertise. The self-care aspect is crucial in addressing health for populations. We have technology partners. We have Novo Nordisk, who brings the preventive side for obesity and diabetes. So it is a question of really making sure the puzzle becomes larger and stronger as we move forward. That is a successful coalition for me.
I really like that analogy of the puzzle, with each piece being distinct unto itself, but as a whole really starts to form a landscape and a broader picture. And yeah, I appreciate that, and also pointing out the distinct but complementary capabilities and capacities of each of the partners. And there's also, I think, a little bit of alchemy involved in the sense that there needs to be aligned goals and principles and values. And so, Daniela, I'd like to turn to you, and also the reference to Bayer. You announced the partnership about a year ago, I believe, between the Novartis Foundation and Bayer. And I'm wondering if you could share a little bit more about your experience, what's transpired since, and what was really attracting you and Bayer to a coalition of this sort.
Well, thank you. And first of all, it's good to be here. I'm reflecting on being here a year ago, and then subsequently announcing the partnership. And I think I have a few reflections coming out of that. So one is, when we're talking about coalitions here, it's not just about a logo on a wall. It is really an operating model that we're talking about. And one of the lenses that I look at these things through is, we hear a lot about partnerships, you hear a lot about pilots, and at the same time, pilots can suffer from pilotitis. And so the piece that I always look at is scale. how do we really drive scale and impact? And I would say that's at the heart of what I'm always looking for in partnerships, and it's one of the reasons I've been so impressed with what we're doing on Cardio for Cities and the why, right? So why is Bayer doing this? Why are we interested in this? We've been in the cardio space for a very long time as the makers of aspirin, and we also have our 100 million goals, and one of them is to expand access to everyday health for 100 million people by 2030. And we've learned a lot going through that journey, including some of what you heard on the earlier panel around issues of time poverty, access, convenience, health education and literacy, meeting people where they are. And I have a fundamental belief that if we look at where healthcare is going, and if you look at the data and even what former director of the CDC in the US said, if we get it right in the next decade, 90% of care is going to move closer to the home and to the community. So we need to meet people where they are. We need to engage community health workers. We need coalitions that are really operating models for delivering impact at scale. And then we need to replicate the things that work and have a very fast learning loop. And these are some of the things that we're doing here, which is what I find most exciting.
Excellent, thank you. I hadn't heard pilotitis before, so I'm definitely going to remember that. And also want to come to this notion of scale in just a moment. But Lin Lang, I'd like to turn to you next to go a little bit deeper and on the reflections note, learn from your experience in Sing Health and how a tech-enabled and data-driven platform has really enabled you to understand population health more deeply in your context and how this partnership has enabled that to happen.
Right. Yeah, thanks a lot, Alison, and it's really wonderful to be here. Good morning, everyone, and greetings from Singapore. I think in Singapore, we currently have once-in-a-generation opportunity to really converge policy, industry, as well as community partnerships to improve heart health. What we found under AI for Healthy Cities, when we were able to bring both public and private data together, was that we found the importance of social determinants of health and how that impacted a lot on cardiovascular outcomes for our patients with diabetes. We also found that physical activity was protective of reducing complications from cardiovascular complications from diabetic patients. So in July 2023, for Singapore, we actually embarked on the nationwide transformation program called Healthier Singapore, and that prompted each Singaporean citizen to enroll with a family doctor. And 3 years on, we're happy that more than 60% of our population have enrolled with a family doctor, and that's really important to build that longitudinal doctor-patient relationship. We're also supporting our general practitioners by forming primary care networks, and that allows our community health workers, like community nurses, to support our general practitioners to deliver better heart health in between their cardiovascular consultations. In addition, we are able to partner with industry to bring continuous glucose monitoring as well as point-of-care testing to support our GPs to better monitor their patients and use some of the CGM data to share back so that they're able to understand the behavioral patterns, the glucose profiles of their patients in between their consultations, and that has allowed us, our GPs, to do this better. I also want to point out that in Singapore, 80% of primary care are delivered by private general practitioners, and 20% are provided by government-funded polyclinics. So to improve cardiovascular health in Singapore, it's important that we bring together a coalition of government policy, supporting our private GPs to deliver better primary health care, and also partnering with industry and foundations to provide that catalytic funding so that we can pilot and experiment how we work better with our GPs.
Great, thank you. I'd love to pick up on some of those learnings and come back on the notion of scale as well in a few moments. But Adine, I'd like to turn to you first. So jumping from Singapore over to Amsterdam, you're hearing about these elements of coalition building, and I'm curious from your perspective in Amsterdam, but also where you're coming from with Philips Foundation, what elements of this coalition framework are attractive to you, and how do you think they could potentially benefit Amsterdam?
Absolutely, thank you, Alison, and a real, I would say, privilege to join this panel. Thank you for inviting me. We are new to this conversation as Philips Foundation, and very pleased, of course, also to join this conversation. And at the Philips Foundation, we do believe that innovation and partnerships and moving quickly to coalitions are the game changer if we really would like to address, let's say, disparities and inequities in access to healthcare. For us, of course, next to scale, I think what is very, very important to us is making the impact or making the impact stick. Let's say, how can we create sustainable models that are indeed scalable, but certainly also owned locally. For us, there are two key thematic areas that we like to focus on, and one of them, which is then the first one, is cardiovascular space, cardiovascular disease. Of course, it is a high burden. We address only underserved communities. And if we bring it to the context of Amsterdam, I mean, certainly as a city, I mean, and connecting to what my colleagues have said, there are so many initiatives, and many of those initiatives are very, very much promising and very attractive, but they're also fragmented. So we see the challenge of many of those initiatives that can have a real impact, but they don't know of each other. Even if we look at it from a players and stakeholders perspective, whether it is from the local government, the private sector, the philanthropy, so we have fragmentation in effort. And bringing those together can really bring a real change, can bring actually also long-lasting impact. And we do believe that's a coalition that can bring all those complementary partners, as Anne said, and also as my colleagues, Danielle also said with respect to pilotitis. I think we have a huge potential to share also our commitment, or let's say our shared responsibility when it comes to accountability, and create that long-lasting impact that can stick and that can be scalable. And scalability, of course, for us, it's not just copying, let's say, what works in a city to another city, but really tailored to what that specific city needs. Because living in Amsterdam, and that is valid for many other cities as well, your postcode may define so your healthy life expectancy, and that is a serious challenge that we see in terms of disparities. And bringing all those actors together, that can be the game changer. And we see ourselves also as a catalyst, as an actor that would love to join this conversation.
Excellent. And you picked up on a number of themes that have been discussed, including a theme this morning about the zip code and where you live really affects outcomes. And I like what you said about, I don't like what you said, but I note what you said about fragmentation and how this kind of approach can really address those problems of fragmentation as well and streamline activity. And also an environment where resources are so constrained and we need to identify ways to utilize resources much more efficiently and in a way that is streamlined to enable that scale and that return on investment, right? So Anne, I'd like to come back to you now on this question of scale, which is often thrown about as well. And when you think about that in the context of cardio for cities specifically, what does that mean? And importantly, how are you thinking about it and approaching it?
Thanks, Alison. That's the million-dollar question. And I start by saying we haven't figured it all out. It is not easy to scale. We have a proven, validated approach that brings very rapid results. In 1 year of implementation, Cardio for Cities in São Paulo tripled blood pressure control rates, reduced heart attacks and strokes by 12 and 13% respectively. Similar results in all the other cities. We are now replicating the approach. So it is currently in more than 40 cities globally, and it works throughout all settings. High, low income, very mature health systems or very underdeveloped health systems. It works everywhere. The reason is that it's a standard, repeatable package, a framework of population health, always keeping the population health lens. Then it is built to be able to use locally adaptable implementation. So you tailor the implementation to what the local priorities are, what the communities want first, or the local city authorities. And thirdly, we integrate all of the evidence-based interventions. We don't have to reinvent what we know needs to be done for cardiovascular health. Frankly, we have all the knowledge, we just don't get it done. So we integrate all the interventions in the existing health systems. We're not creating parallel infrastructures. It's key to scale. And lastly, we bring together the communities with the authorities, with all these different partners to build these coalitions. And we haven't figured out yet what exactly that operational model is going to be, but we are getting there. I feel we are getting closer and closer. And thanks to all these fantastic partners we have here, and many of you are in the room as well who are not on stage, I want to thank you all. Same for the health authorities. I see Ashwin in the room as well, who is a former health commissioner in New York, who helped us tremendously bringing this program to life in New York and translating it into action. So it is really not possible to do this alone. It is a work of many thousands of partners and many thousands of players to get there.
Excellent. To pick up on that a little bit and to also illuminate some of the learnings from Singapore, Lin-Ling, from your perspective and thinking about this notion of scale, how are you utilizing some of the insights, lessons learned from the data and the early stages of the Cardio for Cities and Sing Health? How are you thinking about scaling that throughout clusters in Singapore?
Yeah, thanks a lot, Alison. Under the AI for Healthy Cities, we found three most important factors that impact on cardiovascular outcomes in diabetic patients. The first is the importance of physical activity and how that is cardioproductive. So in Singapore, we have a national program called the National Steps Challenge, and that helps to enroll every Singaporean into a physical activity program. They're given a tracker, they're able to gain points on the system, so it's gamified, and basically they are able to become more physically active and clock their 10,000 steps a day. So that's the first important insight that we found. The second important insight that we found was the importance of primary health care. What we found was that people who had more primary care visits had a reduction in hospital admissions, in emergency department attendances, and ultimately reduced complications, cardiovascular complications. So it's important that we bring primary health care to our patients with diabetes and multimorbidity. And that's why earlier I stressed the importance of supporting our general practitioners who form up 80% of primary care in Singapore. The third is really that co-creation with the community. Because in Singapore, although we are a small country, we found that different ethnicities have different outcomes for cardiovascular. So for example, in Singapore, the Malay population have a lower rates of screening, lower rates of follow-up with primary care, and also a higher complication rate from cardiovascular diseases. So when we go to the community, we really need to co-create what these programs with the Malay ethnicity will look like. And that means going to places of religious worship, to work with the religious leaders, to develop health education materials through storytelling, things that appeal to the Malay community. And that's not something that you would do, and you would do that differently for the Chinese, and you do that differently for the Indians. So really, to add to Anne's point, it really has to be contextualized even within a country to the population that you want to impact on so that we reduce inequities within population. So I thought I'd just share these most three important insights that we found from AI for Healthy Cities and how we're translating that into action under the Cardio for Cities program.
Excellent. Thank you. Danielle, I'd like to turn back to you in the spirit of operationalizing. When you're thinking about partnerships and you're thinking about BEAR and the next steps in this partnership and coalition, how are you thinking about success metrics and how will you track progress? What are those markers and milestones look like for you?
Mm-hmm. So maybe a couple things before I get to that. One of the things that I'm struck by, and again reflecting on being here last year and then being here this year feels a little bit different. So last year there was very much a sense of health is under extreme strain. What are we going to do, and how are we going to tackle that? How are we going to tackle the financial gaps, all of the gaps that we see? And one of the reflections that I have had over the past year is I've received more calls, emails, outreach around, hey, how do we work together and partner? So this spirit of partnership, and specifically coalitions that are driving impact, my takeaway is this is not a fad. This is not a moment. This is where the future of impact in health is moving. And candidly, it's where we all have to move because there are limited resources. We have to prioritize the most effective interventions. And we have to figure out how we do that at scale. And then to your point, meet people where they are, where they live, where they work, where they worship, and how they're actually living every day and their lived experiences. So all of that is to say, when I think about where we're going and where we need to go, there's a few pieces to this. One, we need more of you in the room along this journey with us.
Yes.
I think that's incredibly important. Two, this really is meant to be place-based, community-based, so that it is not just a pilot, but so that it is something that is sustainable over the long term, and then you take that and can replicate it into multiple cities, and you've heard some examples of that. And then the third thing that I am struck by in this moment we're in is, if we're very honest, and we say the uncomfortable part out loud, we have health systems that are based on sick care, not on well care. And we are in the midst right now of a fundamental transformation, and we are all in some way, shape, or form hopefully a part of that, which is how do we transition to a system that is more based on well care, and how do we further incentivize prevention? Because we're here talking about cardiovascular health, but there are a lot of other non-communicable diseases we can talk about. We know that they are largely preventable. In the case of cardio, 80% if you can tackle prevention. That's also what we've learned. So this space around prevention and how you incentivize that so that we don't end up in the hospital as patients. Because by that time, from my point of view, it's already a bit too late. So these are some of the big shifts. So all of that is to say, to answer your question, those are the fundamental shifts I look to see, and you have to get very concrete around what are some of the largest burdens on the health system, non-communicable diseases, cardio, #1 killer. What are the tangible ways to tackle that? How do you flip the script on prevention, diagnostics, access, meet people where they are, do it in a way that's sustainable, and scale it? There are, of course, many click downs on that, but that's the framework that I think about it in, and that's where we're moving.
Yeah, and the answer is prediction. If you predict, you become preventive. And the predictive analytics are now here to be used for that.
And just maybe one last piece to add to that, also to add the hope piece into this, you mentioned precision health earlier. And I want to bang the drum on that, because we are now at a point where we have the data, we have the diagnostics, we have the tools, we can get to precision health. And that's where this is moving. So that's one of the lenses that I also look at it through.
Excellent. We're winding up and ending on incredibly important notes, and also the spirit and energy of coalition building and partnership and leading by example and learning from each other and joining what is increasingly a bit of a movement, I'd say. And so with that, Adine, I'd like to turn to you, and thinking about that and the opportunity here, how are you thinking about that with respect to Amsterdam?
Yeah. Well, I mean, if you listen to Daniela, and actually it sounds like we aligned what I will be saying, but actually we didn't. I mean, that's, but Daniela said actually we need more people in the room, right, to join. And I would like to say we do. I mean, I am very much proud actually to announce that the Philips Foundation is joining as a coalition partner to support Cardio for Cities in Amsterdam. We have been following, of course, Cardio for Cities progress in many regions and many cities, and we see that this initiative, bringing then the City of Amsterdam, the different key stakeholders, the healthcare providers, the philanthropy, the Novartis Foundation, Philips Foundation, and many others, actually to address inequity in access to cardiovascular health. I think that is what drives us in this initiative. We do believe so that actually the elements that will be addressed here will really help the City of Amsterdam to leverage data in terms of learning, adapting, and reducing inequities. And I think the elements that are attractive also to us in terms of interventions that are more related to prevention, early detection, the cardiovascular coordination in terms of not only diagnosis and treatment, but certainly coordination of the continuum of care, and then, of course, also the responsible use of data.
Excellent. So that's very exciting news about Amsterdam and about the Philips Foundation, and thank you for sharing that on this stage. And I think that begs the question then, who else in the room is going to join in?
Yes.
So thank you all for your work. Thank you for joining us today, and we're excited next year to come back to see what has happened and how you've all grown. Really
Thank
appreciate
you,
your time
Alison.
here today. Thank you.
Thank you.
Ladies and gentlemen, please welcome back to the stage foreign policy publisher and CEO, Andrew Solinger.
Lots of exciting announcements today here on the stage at our Healthy Cities discussion. So I think we pretty effectively made the case that cities are not just where health challenges are visible, but really where the rubber hits the road, where solutions are most actionable. We spoke about metabolic disease prevention and women's cancers and AI-enabled population health tools, coalition building. The conversations again and again turned to the thought that healthy cities are not built through isolated interventions. They're built through partnerships, and we've heard that repeatedly. I want to thank all of you, actually, for coming and joining in that discussion. I agree with what this panel said. We need more people in the room. You are the people in the room, so thank you for coming and filling the room. I also want to thank our partners, McKinsey Health Institute, MSD, the Novartis Foundation, Novo Nordisk, and the Rockefeller Foundation. Again, we could not have done this without their help. And also, of course, all the speakers and all of you in the room. We need more people in the room, actually. Tomorrow, we have another discussion on menopause called Menopause Matters. It'll be at the Vaubois restaurant right across from the Intercon. It's very nearby at 1:30. Very, very important discussion. We began this focus on menopause last year at WHA, one of the first discussions of its kind, and it is now becoming, I think, it's getting the importance and attention that it deserves. So please join in that one as well. We're actually going to have registration cards outside with QR codes, so if you're not registered, you could just take a quick pick and register right there outside. See my colleagues. I also want to remind you that FP does a whole slate of programming on healthcare at the UN General Assembly in New York each year in September. We'll have all of that information up on our site, foreignpolicy.com/events. Please do check it out, and please do join us there. Thanks so much for joining us. I really appreciate your time.